So we are really, really excited to be able to have Dr. Putrino here with us today to answer some of those questions and help us all feel a little bit more informed as we do the important work of going out into our communities and talking to them about COVID-19 and long COVID as well. I'd love to just hear from folks who's in the room. So if folks want to use the chat function to just share your name and where you're coming from, or what organization you're representing, what neighborhood you work with, whatever you want to share about yourself, and maybe a word about how you're feeling today, that would be great. And we'll get into introducing Dr. Putrino and getting the conversation kicked off. My dog is very excited about it. She will be crying because she moved from a position in which I can't easily pet her and she wants to go outside. But really looking forward to hearing who's in the room. So please, please, please use the chat function to say hello to all of us. And I will go ahead and introduce Dr. Putrino. So Dr. Putrino is here with us today. He holds a PhD in neuroscience and is a practicing physical therapist. Currently, he's the Director of Rehabilitation Innovation for the Mount Sinai Health System and an Assistant Professor of Rehabilitation Medicine at the Icahn School of Medicine at Mount Sinai, where he works to develop technology solutions for individuals needing better healthcare accessibility. Dr. Putrino is also an official medical provider for the Red Bull sponsored athletes in North America, which is super cool. And previously he worked as a clinician in Australia before moving to the US to study computational neuroscience at Harvard Medical School, MIT, and NYU. He has also served as a faculty member at Weill Cornell and Burke Medical Research Institute. We are really, really happy to have you here with us today, Dr. Putrino. Can't wait to learn from you. I'm going to spotlight you for everyone and let you take it away.
Okay. Thank you so much for having me. It's great to be here. I'm going to go ahead and share my screen. Today is all about just sharing information that I think might be helpful for us as we explore long COVID and try to get a handle on all of the problems that we're seeing. I tried to prior to putting this presentation together, I was given a list of questions to try to answer with this presentation, but as Devin said, we've got 45 minutes to an hour, so ask lots of questions. I'm just here to share as much as possible. So let's get going with that in mind. First things first, working definition of long COVID, by no means perfect. This is how the CDC currently defines long COVID. Long COVID and or PASC, which we will get into in a little bit. So really, basically what the CDC is saying here is, listen, anyone who has an acute infection with COVID-19 and then goes on to experience new, returning, or ongoing health problems, new being new health problems, returning being something that they thought they were over, has returned and is worse, or ongoing meaning they already had some chronic conditions and now those chronic conditions have accelerated in their severity. The CDC will recommend this is all post-acute sequelae of COVID. I want to highlight a few things. CDC talks about being experienced by people 4 or more weeks after an initial coronavirus infection. World Health Organization says 12 weeks here. In our clinic and our lab, we tend to align with the World Health Organization simply because there are a lot of people who experience a long tail recovery from COVID. So they get COVID and at 4 weeks, they're still not feeling right because it's a severe virus and it knocks your system around. But then by 12 weeks, they have recovered. They feel like they don't have persistent symptoms and they're doing well. The reason for this differentiation here is we want to be careful not to create a narrative that if you just do nothing and wait, spontaneous recovery from long COVID occurs. That is not the case in long COVID. And so we need to be very, very careful about how we define things, because otherwise there can be an unhelpful narrative of, well, yeah, I did get diagnosed with long COVID, but I rested for, about 3 or 4 more weeks and then it just went away. That is not the experience that the majority of folks with long COVID are having. The other thing that I want to point out is this idea of conflating long COVID and post-acute sequelae of COVID. The CDC does this. The long COVID community is less hot on this conflation. I agree from a scientific perspective, it is not a good idea to merge these terms. Although I will acknowledge that I have merged these terms in the past as we were learning about long COVID. And I think that, we're all evolving in our understanding of how to frame these issues. I'm going to try and frame it a little bit more clearly with a just a diagram. So this, I think, can be helpful as we're thinking about framing. So post-acute sequelae of COVID, in my mind and in most people in the community's mind, really encompasses everything. So post-acute sequelae of COVID, PASC, can just be anyone who is experiencing any change or new or ongoing symptoms after their acute COVID infection. Now, this also encompasses really clear and noticeable organ damage. So, for instance, someone has COVID pneumonia, they go on a ventilator, they experience lung damage, they don't have any of these syndromic symptoms that we've been seeing in people with long COVID, like fatigue and post-exertional malaise and cognitive impairment. They just have lung damage. And therefore, they can get successfully treated with pulmonary rehabilitation, stuff that we already know how to do, and that's totally fine. Someone else might experience acute kidney injury, which is another very, very common sequelae of COVID-19 infection. And again, this doesn't necessarily mean that anybody needs to go into a long COVID rehab program. It just means that they need medicine for their damaged kidneys, or they maybe need a stent placed, they need a urologist's care, and they can get on with their life. So understanding the difference between folks who have discrete organ damage from an acute COVID infection, and understanding the difference between individuals who have symptoms that look more like a syndrome. So people who are experiencing dysregulation of their autonomic nervous system, the part of our nervous system that does all of the automatic things that we usually don't think about, like blood pressure regulation and heat, and temperature regulation and hormone cycling and so on and so forth. When that gets knocked out of balance, it's called dysautonomia, and it's very syndromic because you have all sorts of vague and often subjective symptoms, but vague but very intense, all hitting you at once, and it's hard to diagnose with a blood test. This fits into the bucket of post-viral dysautonomia, and it looks more like a syndrome than it does like a discrete organ injury. It needs to be treated differently. People with post-viral autoimmunity, people with signs and symptoms that are consistent with a diagnosis of myalgic encephalomyelitis or chronic fatigue syndrome, these are the groups that we think about when we say long COVID. Everything else we think about as PASC, a post-acute sequelae of COVID. But we do need to acknowledge that there is this offshoot of long COVID that tends to be a little bit more syndromic, and much harder to treat with our conventional standards and models of care. I get how confusing this is. I really, really do. But we can ask lots of questions about this and talk about it, because I think that it's important to know what we're treating. So, I mean, the simplest way to place it is that, you know, everything is PASC, but not all PASC is long COVID. So what does it look like? Again, we need to be very inclusive in symptoms associated with long COVID. I think the most complete paper to date was that was published by Davis et al. In the Lancet. It was a patient-led research study, which is always phenomenal to see. And what they reported was that long COVID can report as 205 or more than 205 presenting symptoms affecting every organ system in the body. So it can look a lot of different ways. You can have a lot of presenting symptoms. The most common cardinal symptoms of long COVID are post-exertional malaise. So a feeling of severe symptom worsening after activity takes place. So any form of exertion, this can be physical, this can be cognitive, this can be emotional, this can be something that we don't usually think of as exertion, such as digestion. So just being cognizant of the fact that lots of different things can be exertional. But the most common post-exertional symptoms, post-exertional malaise, extreme fatigue, cognitive impairment, and heart palpitations. These are some of the most common symptoms that are reported, but then there are also, as we can see, many, many others. And really focusing on just listening, taking a careful and complete cataloging of the symptoms that are being reported, and where possible, using well-validated patient-reported outcomes to measure the severity of the symptoms, so that you have an objective measure for the subjective symptom that is being reported. So for instance, if somebody says, I'm fatigued, you don't just write down patient says they're fatigued. You should say, okay, you're fatigued. We're going to measure your fatigue on the fatigue severity scale, which is a very well validated metric of fatigue, so that we have an objective score for how fatigued you are. And that way, if you're applying for long-term disability, or you're applying for, or you're speaking to your insurer, we have an objective biomarker for how fatigued you are that is hard to argue with, because these biomarkers have been used in FDA studies for different drugs and different interventions for many decades. So it's a nice strategy to make sure that people who are reporting subjective symptoms can still be heard. In terms of other things that I think are important to note about what long COVID can look like, long COVID symptoms can stay sort of simmering below the surface until people do something that triggers them. And I think that that is also a very frustrating part of the long COVID experience for many patients, because they get a lot of, well, you look fine right now, from health providers, employers, even family members, which can be incredibly challenging because it is an intermittent illness. You can have a baseline level of symptoms that are fine, they're manageable, you feel a little crappy, but you can get through your day. But then certain things will trigger long COVID symptom attacks, where this can cause symptom flares that will last days to even weeks, that are hard to recover from. We published a paper earlier this year showing that the most common triggers of symptom attacks are physical and cognitive exertion, stress, dehydration, weather changes. So a lot of people with long COVID, for instance, we know from our clinic, are struggling right now with the extremely hot and humid weather, consuming large meals, premenstrual period, alcohol consumption. So these are some of the most commonly reported triggers, but also again, just like it's important to carefully catalog symptoms, it's also important to carefully catalog what will cause a known trigger of of these symptoms. So who is at risk? I hate to be a doomsayer, but everyone is at risk. Everyone is at risk of long COVID. Now I know what you're saying. Surely not everyone. Yes, everyone. We've been working and collaborating with the World Health Organization. This is an issue that affects every race, people of every ethnicity. We're seeing similar numbers with our colleagues in Brazil and our colleagues in Europe and our colleagues in Asia. Everyone is reporting this range of 5 to 30%, depending on where you set the guide rails for diagnostic criteria. I know that people talk about, hey, what about the vaccines? It may reduce risk. We have emerging and promising evidence that it reduces risk, but it doesn't eliminate risk. I know that people are saying, but variants are less severe. Again, it may reduce the risk, but it is not eliminating risk of long COVID. And the most conservative paper that is out right now, and I want to point out, this paper was criticized for being sloppy in its methodology and too conservative in terms of what it classed as long COVID. It was really hard to get a subjective diagnosis of long COVID in this study. So they closed out a lot of people who were experiencing symptoms, and they said, no, that's not really long COVID. So even in this paper, it places risk of a person who survives Omicron, who is double vaccinated, at 5% of going on to get long COVID. So that is a number that should really worry us. It should really worry us for a lot of reasons, not least of which being that we're hearing government policy saying you can take off masks in planes, you don't need to wear masks in the subway, you don't need to show proof of vaccination in large areas where we're dining. I can't stress strongly enough that these policy recommendations are starkly going against science, and they're starkly going against public health recommendations. And I can't advocate strongly enough that every single person on this planet is at risk of long COVID. I've lost count of the number of people who say, hey, I used to run marathons. I was in peak physical condition. Now I have long COVID. There is some emerging evidence, but nothing has been published convincingly just yet, that individuals who have a history of autoimmune disease may have an increased propensity for long COVID. So that is something to, I would say, just be aware of when you're speaking with your communities, that individuals with autoimmune conditions should try to protect themselves even more if at all possible, because those data are emerging, but right now I would say that they're still anecdotal, and we should be careful. In terms of when to see someone about the symptoms that you're experiencing, I really want to point out that long COVID can at first present as really mild illness. So in a recent study that we did, where we were recruiting for individuals with long COVID, as well as individuals who had fully recovered from COVID. We had to recruit around 50 individuals who had fully recovered from COVID, meaning they had a COVID infection, and they'd had a COVID infection, and then 12 weeks later, they considered themselves to be fully recovered. What was interesting about this study was out of 100 phone calls that we made to 100 different people who were volunteering to be a part of this study, that was how many calls it took us to get to 50 people, because the other 50% actually failed our screening. They considered themselves to be fully recovered, but when we pressed, we used a standardized semi-structured interview to walk through, do you have this symptom? Do you have that symptom? Are you sure? all of a sudden they started saying, well, actually, yeah, I am recovered, but I haven't been to the gym since I got COVID because going to the gym makes me really unwell. Or, yeah, I've had to take a few more extra days off work because I just haven't been able to finish out the workday. And all of these things of lingering fatigue and headaches and GI symptoms that weren't there before lead us to believe that long COVID in its early phases in a lot of people could just be, again, simmering below the surface, waiting for the next immune hit to come out with stronger symptoms. And a lot of people are presenting as just, I can't quite shake this. I can't, I don't feel right, but it's definitely not long COVID. I'm just taking time to recover. So we always try to err on the side of caution and get people more complete medical records sooner rather than later. This is important from an advocacy standpoint, a self-advocacy standpoint, and it becomes much more important in historically excluded groups to get a complete history of this is when my symptoms started, because it makes it that much harder to deny long COVID when we're 6 months out, 8 months out, and then there is a big symptom crash. And then, a physician might say, oh, well, this isn't related to COVID because you had COVID 6 or 8 months ago. You didn't have it, 4 weeks ago, like the CDC said. So we're always encouraging people to make sure that they don't delay in seeing a provider. If they feel like they're having a slow recovery from COVID, get in there and, make sure that the physician is aware, make sure that the physician is already thinking long COVID and linking it to your recent acute COVID disease so that there is no difficulty later on. And to that end, especially in historically excluded groups in the healthcare setting, I cannot stress loudly enough, get any documentation that you can of acute infection, whether that be antibody testing, whether that be PCR testing. Make sure that it is on record formally that you had a COVID infection, because right now the CDC is saying that you don't need formal diagnostic criteria, but who knows? If administration changes happen, these changes may happen to reduce the amount of services that we're providing to a population in need. And we all know that this will lead to certain populations being prioritized over others, and it will create disparities in health. So the strongest thing that I can say, if you take anything away from this talk, is it's this slide. Make sure that even if people are just feeling a little off and they think they'll get better, make sure their provider knows about it. Make sure their provider documents it. Make sure that there is formal documentation that leads, that draws a link between acute COVID and lingering symptoms. How to prevent long COVID is really simple. Just don't get COVID. Again, right now the data are very spotty on exactly how much vaccines or the new variants will reduce your risk of getting long COVID. The only protection we have right now, this is a really short slide and short message, the only protection we have right now is not getting COVID. Take yourself out of situations where you can, where people aren't exhibiting safe COVID behaviors. Be willing to speak up where possible, where it's safe to do so, about people adhering to mask mandates and social distancing. Right now, that this is the only defense we have against long COVID, is avoiding initial infection. So then it comes down to research. What are we doing? What are we trying to push forward? We need to initially just address the unknown. And the unknown right now is understanding the different subtypes of long COVID. So like I said earlier, long COVID is lots of different things. It's not just one condition, it's many conditions. We have immune theories, we have microclot theories, we have viral persistence theories, we have all sorts of different things. And it is so important that right now we do meaningful research to understand what symptoms are being driven and what pathologies are driving the different types of long COVID that we're seeing. Because unless we do this, a lot of our interventional trials are going to fail. You know, a concrete example of this is everyone is calling for Paxlovid clinical trials for long COVID, because there is a good chance that viral persistence is causing some long COVID cases. However, if we don't have good methodology to identify long COVID cases that are caused by viral persistence, then a Paxlovid clinical trial is going to fail, because you're going to give Paxlovid to 300 people with long COVID, but only 50 of them have viral persistence, which means that only 50 of them will get better and the other 250 won't. And that's why it's very important for us to start understanding which type of long COVID is being caused by which mechanism. The only thing I can promise you right now as a researcher with 100% certainty is that it is not all one mechanism. I have seen enough data at this point to make that with 100% certainty. Long COVID is more than one condition, and we need to understand distinct, targeted precision medicine strategies for each one. I think we need to eliminate siloed research. We need to start collaborating more as a group as we start to explore scientific research. We need to explore novel ideas. This is a message for the Recover Initiative. They are looking in the same old places that we've looked for 50 years. We're not going to find anything. We need to be looking in new directions. We need to be looking for things like microclots. We need to be doing detailed and novel immune assays, because the regular cookie cutter blood tests that you get at any typical PCP appointment will not show up as abnormal. These are things we know right now about long COVID. So encouraging researchers, encouraging policymakers, encouraging hospitals to look outside the box and push collaborators from different disciplines to work together, I think is really important. A few concrete examples of that happening in my world right now, just so you guys know. We know that there are a few leading theories about what might be causing long COVID. The first is viral persistence. This is the idea that certain individuals are not clearing the virus. So they are still experiencing this sort of low-grade subclinical viral infection that is causing their symptoms. This is something that really needs to be looked into. There's another theory that we have chronic inflammation, so that that COVID, being a novel virus, caused a proliferation of inflammation. It really flared the body up. We've all heard the term cytokine storm. Really what that means is that our immune system shot out so many inflammatory cells in response to the virus that it became toxic for our body. And many people think that this acute inflammatory response that then cascaded into a chronic inflammatory response is causing toxicity in the body and causing symptoms. And then finally, there is this idea of autoimmunity that, again, the immune response was so extreme and so unusual for our body because it was an entirely novel virus, that now we have the body starting to use the immune system to attack itself. So the immune system is now really starting to attack its own body tissues and causing all sorts of problems for people with long COVID. So these are some of the theories. There are many, many more. We're currently investigating a lot of these. Again, to the point of breaking out of our silos. I'm a physical therapist with a PhD in neuroscience. Akiko Iwasaki from Yale University is an immunologist. Never in a million years did I think that I should be working with an immunologist in my research. I typically do robotics for people with spinal cord injury and brain-computer interfaces. This is a whole new frontier for me, but we need to learn. because this is the only way we're going to make breakthroughs. So Akiko and I have been working together to do deep immune profiling on a large cohort of individuals who are either COVID naive, i.e. have never had a COVID infection, have long COVID and have a solid diagnosis of long COVID, or have experienced COVID and fully recovered. We actually hope to be releasing the first paper of our collaboration in the next week or so, as a preprint. So keep eyes out for that, because it really pushes out some compelling information about how long COVID patients are distinctly different in their physiology now to members of our control groups. On the viral persistence front, I'm now working with Saurabh Mahandru, who is a gastroenterologist at Mount Sinai, and Amy Prohl, who is a microbiologist from the Polybio Institute. Again, two groups that I never thought I would have to work with or need to work with. And we are currently studying the role of viral persistence in producing certain long COVID symptoms. In this particular study, we're looking at long COVID and GI symptoms. And we're trying to understand how this persistent virus can be interacting with surrounding tissues and causing the symptoms that we're seeing. And then finally, I'm working with a hematologist. Again, why should I work with hematologists? I don't know, but working with a hematologist by the name of Ricia Pretorius. Ricia made a stunning and very influential discovery that individuals with long COVID were producing these microclot-like entities in the blood. So these are clots that do not show up on regular clotting assessments that test for large blood clots, but they are in fact microclots, and they do in fact have enough utility to block small vessels and cause issues. And in one of our earliest collaborations, we've already seen a strong negative correlation between the number of microclots you have in a blood test and your performance, your cognitive performance on an executive function task. So the more microclots you have, the worse you did on the cognitive task. So this is a really compelling finding that suggests that microclots might be driving some of the pathologies that we're seeing. So once again, all of this is just to show that there is ongoing research occurring. The research that we view as important is focused on understanding all of the different subtypes of long COVID, which will lead us to actionable precision medicine treatments. And the only way that we're getting there and making progress is by breaking the mold of traditional research, breaking the mold of what, the incremental innovation that is typically funded by NIH, and working on disruptive innovation projects with people from different fields. In terms of addressing misinformation, we wanted to have a brief, slide about information regarding long COVID and vaccines. I want to state really strongly, because I don't think that we should shy away from discussing negative consequences of vaccination. We just need to be, because folks have read about it anyway. Like, let's not pretend that it's not out there, whether it be conspiracy theories or actual science. If you go out and your messaging is there is no problem with the vaccine, you're going to get caught up, because there are lots of data that are out there. There are lots of publications that are out there written by people who are not anti-vax that show that vaccine injury is real and it can be debilitating, and it does resemble long COVID. But I think the nuance here and the important part of the message is it's extremely rare. So while long COVID happens in 5% of the population of people who get infected with COVID, vaccine injury is happening in 0.001 or 0.0001% of individuals who get a vaccine. So the idea idea here is your risk of severe and debilitating symptoms is still much, much higher if you don't get vaccinated and you go on to get the virus than if you're vaccinated and enjoy protection from the virus. However, I think it's important that we don't dismiss or alienate people with vaccine injury. That has been happening a lot. People are afraid to say, I have these terrible symptoms after my vaccine because they don't want to be viewed as being anti-vax. That adds fuel to the fire for the anti-vax movement, because then they say, see, they're looking to cover it up. Let's be upfront. Let's talk about it. Let's be adults and have adult conversation about it. It's because it is a real thing. We're currently collaborating with the KICOS group to better understand mechanisms and how to identify cases of vaccine injury. And in the meantime, Science Magazine published a really well-nuanced article about this. And so I would really recommend Googling vaccine injury in Science Magazine, and you'll see you'll see a great discussion about it. In terms of additional resources, I've got two for you here. Long COVID Physio is a website that has a phenomenal list of easy to understand, easy to read resources about long COVID. These are very user-friendly and mainstream-friendly resources. We have vetted all of these resources. We've even contributed to some of the articles, and they're really top-notch, and they help to explain symptoms and what to do about some of these symptoms in a very easy to understand way. On the other side of the coin, the American Association of Physical Medicine and Rehabilitation, if you go to their website, they are producing a lot of very science-forward content that is good education for physicians. The intent behind the AAPMR content is, if you're a physician, not necessarily a physiatrist, if you're a physician of any flavor or specialty, and you're trying to understand a little bit more about how you can help and how you can advocate for long COVID patients who are coming to your practice, here's a how-to guide. And so these would be the resources that I would strongly recommend. I'd like to really acknowledge that everything that I just presented and spoke about is a lot of people working. It's not just me. And so I want to thank all of the people in my lab, all of my collaborators outside of Mount Sinai, as well as all of the patients and the patient-led groups that have really helped us to spread the word and advocate. So let's address some questions.
So thank you, Dr. Putrino. It's me, Zizi Ahmed. I'm a community health worker and patient navigator at the Perimeter Cancer Center at NYU Langone. And I'd like to thank you for this informative talk. And clearly, long COVID is an issue of enormous consequence and one that's not quite getting the attention it deserves. And there needs to be more attention to long COVID and calculations of risk about contracting COVID generally. So we truly appreciate you shedding light on it. So right now we are going to turn to the Q&A portion of this talk. And thank you for those who have submitted questions, and please feel free to continue to do so. And I'll pose them to Dr. Putrino. So the first question is, how's long COVID being approached outside of the US? Is it taken more seriously or less, both in a general sense and in terms of research?
Yeah, I think it's a bit of a mix. There are countries that are doing well, and there are countries that are doing poorly. I think all countries are starting to take things more seriously. I would say that the countries that are winning right now are the countries that have socialized medicine, because record keeping is strong. So they have a lot of well-characterized data that allows them to make data-driven decisions about what percentage of the population are living with long COVID. You know, it wasn't until, I think, 2 months ago that the CDC had an estimate for how many people in the United States were living with long COVID. The UK had one a year ago and was continually updating. So I would say that what we could be doing to emulate the countries that are doing well is working really hard to centralize our data sources much faster than what we're doing right now. And then acting on the policy, because that's the other thing about countries that tend towards socialized healthcare, is that they also have a tight link between government and policy. So, you know, the UK sounded the alarm because they said, oh God, 3% of our population have long COVID, which is going to affect labor markets, which is going, you know, and so they started building long COVID clinics, and they started moving rapidly. Not to say that their response has been perfect, because there are a lot of issues with the UK response, but they were making data-driven decisions much faster. And one of the challenges with the US system has been, you know, the CDC released 1 in 5 people who get COVID go on to get long COVID. And then the next day, the CDC said, you know, but still keep masks off in planes, which is just very much at odds with the science. So I think that that's how I've been thinking about this.
Thank you. The second question is, are there any idea what causes the extreme attacks of fatigue, which seems to come on without warning?
So there are many causes of extreme fatigue in long COVID, but we have good evidence for two main types of fatigue or post-exertional symptoms that occur in long COVID. The first we call metabolically led fatigue. Now, for the last 30 years or so in the myalgic encephalomyelitis community, there has been a lot of research showing that people with ME/CFS have what's called mitochondrial dysfunction. Mitochondria are the part of our cells that produce energy for the cell. And what happens when you have a viral infection is the virus actually hijacks the cell, and it hijacks your mitochondria, and it starts leaching power from the mitochondria to produce more virus and spread the virus through the body. That does two things. First of all, it decreases the amount of energy the cell has for you, but it also starts making the cell overproduce energy, which causes damage to the mitochondria, and it causes the mitochondria to produce more waste products, which are toxic to the body. And so some people have this metabolically led fatigue. We don't know if it's because the body has just been damaged, you know, the mitochondria have been damaged by the virus and they're sort of limping along trying to recover, or that the virus is still there, still leaching energy. But we see that individuals have these attacks of fatigue. They seem to be random, but they're usually not random. They're usually linked to exertion. But the problem is the definition of exertion can change. Like I said, digestion can be exertion. So, you know, one of the things that I often find fascinating with people with this sort of metabolically led fatigue and post-exertional symptoms is they'll try and eat healthy, but a lot of healthy food takes a lot of energy to break down because it's high in fiber and it's high in all of these wonderful nutrients. Whereas they say, you know, if I eat McDonald's, which is just like simple sugars, like I don't get this crash afterwards. I can just go through, and it's, yeah, that makes sense because your symptoms are triggered by exertion, and the McDonald's is easier to digest. It's less exertion than something that's super high in fiber and complex proteins and so on and so forth. And similarly, even just cognitive load, or, you know, being in front of a Zoom screen, or having an emotionally difficult conversation can be exertion that causes people to sort of tip off the edge. So that's one form of fatigue. The other form of fatigue is we call it autonomically led fatigue. So this is when we have our autonomic nervous system knocked out of balance. And typically the way that this works is the autonomic nervous system is kind of incredible in what it does day to day, because, so a quick, for instance, of what the autonomic nervous system does is if I go from sitting to standing, it will automatically quickly regulate my blood pressure so that my brain is still getting the same amount of oxygen, same amount of blood, and I don't feel faint or dizzy or like I'm going to pass out. And it does that by being, tightly calibrated on a dial. Now, if I experience damage to my autonomic nervous system, this dial, like this very well calibrated system, actually starts to operate more like a switch, where I'll go from fight flight, my heart pounding and my adrenaline up, to rest and digest, where I just feel like, I need to sleep and I need to hibernate, and it's going to be hard to wake me up. And people with autonomic dysfunction after COVID, which can happen because the immune system sort of damaged their autonomic nervous system, they often experience this more autonomically led fatigue, which means that, they will eat a meal and their stomach will stretch, and that stretch stimulus says, okay, you're full now. And rather than, this dial coming in and them shifting slightly back to parasympathetic, it switches and it goes, you're full now, hibernate. And they get what we call postprandial fatigue. They feel like, honestly, like someone switched a switch on the back of their head and they need to power down. And so suddenly they can't keep their eyes open no matter what they do. They feel like someone has, put a tranq dart into them and they're just going down. So those are the two types of fatigue. Those are the mechanisms behind it. We're trying to better understand these mechanisms by studying metabolic function and studying autonomic function. These are not part of standard physical examinations that occur in a long COVID clinic. So we're starting to capture data on this to better understand how each contributes to the fatigue. I know that was a really long-winded response, but it's a complex topic. It's a prominent symptom with a hard to explain mechanism.
No, actually, thank you, because we need to get this kind of information that we really don't hear about very often. The other question is, can individuals get tested for viral persistence if experiencing long COVID symptoms? And if yes, how long after COVID infection should they consider getting tested?
Yeah, so currently there's not an available test for viral persistence that is covered by insurance or recognized medically as an issue. This is part of the research that we're doing with Sarab and Amy Prohl, is to really try to push this line of inquiry forward. And the other thing, and in fairness to everybody involved, the other thing that we're trying to understand is exactly this question of the study that we're doing is not stopping at just identifying whether virus exists in the body. It's doing these advanced techniques that actually aim to understand, okay, there's virus, but is it causing damage? Is it just minding its own business, or is it actually leading symptoms? Because it may be that after a COVID infection, yeah, you do have spike proteins and partial bits of the virus hanging around in the body for a year, 2 years, as the body sort of takes out the trash. But they may be doing nothing. The goal behind the research that we're trying to do, which is very novel, is we're using a technique called reverse transcriptomics that will allow us to look at all of the tissue around where we find the viral persistence and see if the virus is causing inflammation, if it's changing the genome of the tissue that it's embedded in, all of these things that can tell us it's not just persistent virus, it's pathological persistent virus.
All right, another question is about messaging, because there's COVID fatigue, but I think So many of us have also mask fatigue. So how do we message around long COVID to people so that they do follow precautions like masking when there's so much fatigue around trying to prevent COVID for so many years?
Yeah, I mean, I think this is a tough question for sure. I think that honestly, in the conversations that I've had, it really just comes down to more education about what long COVID is. In most of the conversations I've had, I think I've been able to sufficiently calmly and sufficiently scare people about long COVID where they're just like, pull a mask on, because I still keep bumping into just, members of the population as well as physicians who, I've not really heard about long COVID, and this sounds unbelievable to us who live in it, but it's real, like, I guess it's just not in their sort of bubble of media and news. And so it's not reaching them. And then they say, well, how bad is it really? And then I explain, like, okay, I've got a guy who did 4 Ironmen, in Hawaii, and now can't get out of bed and can't work and has gone on long-term disability, and family is breaking apart, and so on and so forth. And it's just the sort of matter of explaining what we're talking about and explaining the severity that it can reach with relatively mild nothing symptoms. I think that the biggest mistake we made in public health messaging was saying the only thing we care about is hospitalization and death, without anticipating a post-viral illness occurring after this virus that tore through the population. And I think that undoing that messaging and saying it's not just about who gets hospitalized and who dies. Yes, you're fit, you're healthy, you're in good shape. You probably won't get severe disease from BA5, but there's still a 5% chance that it will wreck your livelihood. So why not pop a mask on? Why, there's no reason not to.
Exactly. I can't strongly agree with you. So thank you again. Thank you so much for taking the time to be with us today. And right now, I'm going to hand the mic to Temnit and Danielle. Thank you, everyone.
Hi, thank you so much, Dr. Putrino. That was very helpful. We definitely need to do more messaging around long COVID, and so that people are aware of like the risk that they're facing. So we're in our last 5 minutes, and I just wanted to make sure to drop here the feedback form. We want to make sure to continue to provide training and presentations that are relevant and important to you. So please fill out the feedback form. It's really helpful for us. And second thing, I also wanted to tell you about the focus groups that we're hosting, CHW and Navigator focus groups. And this is really to help us understand your experiences and challenges that you're facing on the ground doing COVID-related outreach and education. Our next session is going to be on August 3rd at noon. So if you already haven't participated in one, please consider joining us. They're normally just like around 90 minutes long, and we have a small gift card as an appreciation of your time. So please just shoot me an email if you're interested, and also feel free to share it with other CHWs who might be interested. I'm dropping my email in the chat. So, thank you, Devin. And I think I'll just pass it for Danielle.
Hi, everyone. Thanks for joining today. And thank you, Dr. Putrino, for that amazing presentation. We will be sending out the recording and the slides and the resources that he mentioned, which are all great. Also wanted to take the time to plug our TikTok challenge campaign that we launched recently to engage New York City youth in the conversation around COVID, vaccines, misinformation, the importance of boosters. We're extending the deadline so that more youth can participate in the challenge. We also created some social media promotional materials for folks to repost on their organization's Instagram. The winners are going to receive prizes up to $100. So we are asking you all to please promote to your youth so they can participate in this challenge. And Devin put our new Instagram that launched in the chat as well. So follow us, keep in touch, and thank you all for joining us today.
Thank you.
Bye.
Bye, everyone. Have a great day.